Good morning, everybody. Thank you all very much for coming today. My name is Henry. This is Danny. This is Justin, and that's Sara. And together we worked with the Institute of Medicine of the National Academies in Washington, D.C. to evaluate the hospital preparedness program in the state of California. Now, I want you all right now to imagine that you are in a natural disaster tomorrow. Whether it be an earthquake, a flood, or a hurricane, there will be massive infrastructural damage, but more importantly, thousands upon thousands of people in need of desperate medical care to save their lives. What hospitals have to do to respond to such a situation is overwhelming. They'll have to figure out things like whether they have enough juice in their power generators to keep the lights on and machines running for the next few days. They will have to figure out how to take the patients that don't need emergency medical care within the hospitals out of their hospitals to take on more patients. And to do that, they'll have to figure out transportation options to nursing care facilities or to home care organizations. This is very overwhelming for hospitals, and this is just the beginning of many things that hospitals have to do, and this is what motivates our work. So, to begin, we'll be giving you a background about disaster preparedness and the healthcare preparedness program, then look into research questions that we want answered and the methodology we use to do this. Then we'll tell you about the results that we found, discuss these results, and finally make recommendations for future research. To begin, there are many types of definitions for emergency preparedness, but the one we like to use is emergency preparedness is the extent of a hospital's capabilities to meet the needs of a substantial influx of patients due to a public health disaster. Public health disasters are not just limited to natural disasters like we talked about before. They could be pandemics like influenza or Ebola, or even mass casualties like the Air Asia plane crash that happened just last year. There are also a number of metrics that researchers use to figure out how prepared hospitals are. These metrics can include things like developing emergency plans for surge capacity, ensuring that hospitals will be staffed during an emergency, purchasing all the necessary equipment and medications to respond to an emergency, and finally, training staff. Unfortunately, our hospitals across the nation are vastly unprepared for large mass casualties. The Weapons of Mass Destruction Research Center, which is a bipartisan nonprofit organization in Washington, D.C., looked into the issue of biosecurity preparedness for things like bioterrorism attacks such as anthrax, pandemics, or chemical attacks. And across all these different metrics, when we look at large-scale, non-contagious emergencies, we scored Ds and Fs in every category except for communication, where we received a C. Our federal leaders have realized that much more needs to be done. On September 18th, 2001, you may recall that a rogue scientist sent anthrax to several senators and representatives in D.C. Since then, this was a wake-up call for our politicians to come together and respond to the threat of bioterrorism. So what they did was they passed the Bioterrorism Act in 2002. This allocated billions of dollars for bioterrorism preparedness and established the Hospital Preparedness Program, or HPP. HPP is a program that provides funding so that U.S. hospitals can respond to an emergency either by itself or in collaboration with other hospitals. This program was then renewed in 2006 with the Pandemic and All Hazards Preparedness Act. This again allocated billions of dollars to preparedness, but then shifted HPP from just a bioterrorism-focused organization to one that looked at all hazards, including mass casualties and natural disasters. Finally, in 2013, the Pandemic and All Hazards Preparedness Reauthorization Act reauthorized PAPA throughout 2018. Prior to 2002, what federal funding focused on for hospitals was acquiring supplies like vaccines, decontamination tanks, personal protective equipment, and extra bedding. Now, with the formation of the Healthcare Preparedness Program, the concept of healthcare coalitions was introduced. And healthcare coalitions are groups of healthcare organizations, not just hospitals, but also nursing care facilities, dialysis facilities, EMS transport, any type of healthcare organization in a local region. HPP asked all of their hospitals to form healthcare coalitions so that they can, within a local region, together respond to a disaster. So things like transporting patients from one hospital to another or preparing county-wide drills is of utmost importance to preparedness, and this is what one of the biggest accomplishments of HPP was, encouraging collaboration among hospitals. Having said that, there are issues with the healthcare preparedness program. The biggest one is that it has a significant decline of funding since the Bioterrorism Act appropriated $515 million in 2003 for hospital preparedness. Currently, when we look at fiscal year 2015, only $255 million was appropriated, so this is a large drop. What this translates into today is just $5,000 to $40,000 allocated per California hospital. And this is based on many different factors, including how big a hospital is. But $5,000 to $40,000 is just a drop in the bucket in terms of what a hospital needs to prepare for a disaster. The structure of how HPP funding reaches hospitals are another issue. So currently, HPP allocates money directly to states based on a formula where there's a baseline amount plus a variable amount based on the population. From there, states have autonomy in how to allocate funding down the line. So at least in California Department of Public Health will then allocate money down to the county level, and counties will then send money down to the healthcare coalitions, and the healthcare coalitions will send money to the hospitals. To clarify, sometimes hospitals receive monies from the state and the county levels, but in the vast majority of cases, they receive money from their healthcare coalitions. There is a large variability in California in how hospitals receive funds. Some hospitals receive much more money than others, even among the same size, and there's no real formula that we were able to find in how this was done. Other states have very different funding structures. So our group wanted to focus on California's HPP program in particular. In California, we received $23.3 million of the $255 million allocated to HPP in 2014. We wanted to compare our preparedness levels to Texas, which is the second largest state in the United States. And across different metrics like the number of hospitals participating in HPP, to the number of trauma centers, the number of staff beds, and the decontamination capacity, California lags behind Texas. So we've looked into issues including the drop in HPP funding to the way HPP funding is allocated. And giving money to states and then giving money to hospitals is just one way of incentivizing preparedness. The federal government has looked into other ways, mainly using a stick. Currently, the Centers for Medicaid and Medicare Services, or CMS, mandates what's called conditions of participation. These conditions of participation have to be met by all hospitals to receive healthcare reimbursement from Medicare and Medicaid. Now, in 2013, CMS asked all hospitals to adhere to other conditions of participation. This was an amendment that was proposed but not yet passed. This amendment asked hospitals to 1. Develop and maintain an emergency plan based on risk assessment. 2. To communicate the plan's procedures to all disaster staff. And 3. Conduct training drills to reinforce these protocols. Now, this proposal is an unfunded mandate. And because of that, the American Hospital Association does not yet support it. They recently released a policy brief that said, "We are concerned that CMS may have significantly underestimated the burden and costs associated with complying with this rule." They even asked all of their hospitals to send letters to CMS to not support this rule. Besides conditions of participation, the Health and Human Services Department in DC has also looked into value-based purchasing program to incentivize hospital. The Value-Based Purchasing Program, or VBP, was established in 2012 along with the Affordable Care Act to incentivize hospitals to improve on medical outcomes. These medical outcomes include things like making sure hospitals are clean enough so that you don't acquire a healthcare associated infection within the hospital, or making sure that heart attack patients who receive treatment do not come back soon after their heart attack for more treatment. So if hospitals perform very well on these criteria, they're rewarded up to 1.5% of Medicare payments. However, if they perform poorly, they will be penalized up to 1.5% of their Medicare payments. So this is in a way both a carrot and a stick, incentivizing hospitals. Now, healthcare HHS officials have thought about using immediate bed availability, or IBA, as a performance metric within the value-based purchasing program. IBA is the ability of a hospital to make up to 20% of its staff beds available within 4 hours of a disaster. They do this largely by triaging patients and making sure that patients who don't need emergency medical care are offloaded out of their hospital and transported to other healthcare organizations.
So there is not a large body of research surrounding emergency preparedness and the hospital preparedness program. But the latest and perhaps most comprehensive review of emergency preparedness in the country came out of the Department of Health and Human Services in 2011. And they looked at hospitals throughout the nation and discovered that most hospitals have planned for emergencies to some extent. Generally, that planning includes staffing, equipment, and transporting patients. What they did find was that only half of those hospitals had actually staged an emergency drill or had made some sort of cooperative plan with another hospital for responding to a public health disaster. Additionally, they found that among hospitals, there was little planning considering the specific needs of children and persons with disabilities during a disaster. Hospitals are beginning to prepare for emergencies, but there still remains much to be done. The knowledge around the hospital preparedness program is even smaller. But the most important study came out of the Center for Bioterrorism Research at the University of Pittsburgh Medical Center in 2009. Essentially, they wanted to study the effects of HPP in its first 5 years. They created essentially an archetype of what an ideally prepared hospital looks like, and then compared hospitals in the US to this archetype. The things that they measured included surge capacity and disaster capabilities, disaster trainings and exercises, collaborative communication systems, and how hospitals actually performed during public health emergencies. What UPMC found was that since the inception of HPP and over its first 5 years, hospital emergency preparedness has improved. Most importantly, healthcare coalitions have developed as the primary coordinators of emergency response. However, UPMC warned that hospitals are still not adequately prepared to deal with emergencies. They said that if hospitals are to be prepared, HPP needs increased funding, and there needs to be an increased emphasis on healthcare coalition collaboration. So, we know what the federal government intends to do with HPP, and we know the literature that's out there about emergency preparedness. But what we didn't know was how this functions at the hospital level. So we went to the source, and we interviewed several emergency preparedness coordinators in California hospitals. We asked them questions about their HPP funding, how much they received, what they thought of the amount they received, whether or not they participated in HPP, and if they didn't, why not, how they used the funding that they received, and the extent to which they collaborate with other hospitals for emergency preparedness. There were 4 main takeaways that we got from these interviews. The first is that the funding stream for HPP grants is complex and varies widely, and this causes a great deal of confusion among emergency preparedness coordinators. It was difficult for them to determine how California decides on funding allocations to their hospital and to other hospitals. Additionally, some of them mentioned that there seems to be a leakage of money in the funding stream. They presumed that this leakage was due to paying salaries for administrative positions at the state and county level, but they were unable to say for sure. Overall, what we gained from our interviews was that HPP could be a valuable program, but that the current amount of funding hospitals are receiving is not adequate. So, we know the federal goals of HPP, and we know that states have a great deal of autonomy in allocating the funding they receive. This led us to our guiding research question. Is California allocating HPP funding in an effective way, and what might be the indicators of that effectiveness? To answer this question, we developed 5 main research questions. These are: 1. Do hospital administrators feel more prepared for emergencies if their hospitals are healthcare coalition members? 2. What is the effect of HPP funding on hospital administrators' perceptions of their hospital's emergency preparedness? 3. Does inter-hospital collaboration increase as HPP funding increases? 4. Are hospitals' expenditures on emergency preparedness well-rounded? And finally, 5. What is the potential support from hospital administrators for these policy alternatives, the CMS conditions of participation, and using immediate bed availability as part of the value-based purchasing program? To gain the data we needed to answer these questions, we developed a survey using the Stanford Qualtrics online survey tool. we mailed letters to emergency preparedness coordinators at 534 California hospitals asking them to participate in our survey. Of those, we received 51 complete responses from hospitals for a 9.55% response rate. Now, there are several limitations of our study that are important to consider, and I will go through each of these individually, but they are small sample size, variability in emergency preparedness coordinators, self-reporting, and the type of data we could collect. First, our small sample size limits the statistical power we were able to achieve. So we could not get statistical significance at the 5% level for any of our results. Second, there is variability in emergency preparedness coordinators, which means that our sample may not be truly representative of the entire population. For some context, some of the larger hospital chains that have many hospitals within them only have one emergency preparedness coordinator who oversees all the hospitals. So if we are to assume then that that one person only completed our survey one time, that means that our target population shrinks even more. The third limitation we face is that of self-reporting, and that means that there may be some biases in the results we received in terms of self-selection and unreliability because we couldn't validate many of the responses we received. And fourth, and perhaps most important, was the type of data we were able to collect. Each emergency preparedness coordinator that we surveyed can only tell us about HPP funding at their hospital. And this means that we were unable to answer some of the broader questions, such as, how does the state allocate funding to hospitals? Is there a leakage of money in the funding stream?
What we'd like to do is give you an overview of the main trends that we found during the course of our data analysis. And we're going to start with some just descriptive statistics and demographic information. So as you can see here in the top box, our breakdown amongst nonprofit, for-profit, and public hospitals was, at least decent. They weren't slanted all in one direction. We didn't have numbers for the state averages for that, unfortunately, but we did for the different types of hospitals. And we got about 80% being general acute care hospitals, which is what we were looking for. It's very close to the state average. We did run a chi-squared test on it. It wasn't supported, but still it's better than having 10. We also got about 70% of the respondents were hospital or healthcare coalition members, which is important because we were trying to study the effect of HCCs on our various considerations. The other table down here is just to reflect the mean responses to our 2 policy approval questions. And just bear these in mind because we're going to talk about them more in Sara's part. So the first trend to notice here is that preparedness score, which was self-reported, is increasing with quantity of funding. So if you get more money, you do feel more prepared. And there's a treatment effect from being part of an HCC. So if you're part of an HCC, you do feel a little bit more prepared than if you weren't. To contrast that, when we looked at collaboration, as you increase quantity of funding, there's pretty much no relationship in terms of more collaborating with more hospitals, which was a little bit surprising. I think we expected to see somewhat of a relationship similar to feeling more prepared. And the next relationship we wanted to put forward was the capital expenditures. So what we did here was we couldn't ask hospitals specifically how much money they spent in each category of preparedness spending, because it was our inference that someone who is the emergency preparedness coordinator might not have access to all the information about the expenditures they'd made over the course of the last fiscal period. They would know what they spent money on, broadly speaking, whether they bought hospital beds, or whether they bought masks, or whether they put in negative pressure rooms. And this was actually the strongest relationship we saw, in that as you go up in funding, the number of categorical expenditures, which we had as a proxy for aggregate spending, went up. We also saw a treatment effect for increased net income, which we gathered outside of the survey and hypothesized that if you had more money lying around that was retained at the end of all your expenses, you might spend more of that on preparedness. So we do see a slight uptick with that. The p-values do decrease, but given that we had a sample size of 50, every time you add a control variable on, it's going to decrease your p-value and your statistical leverage. But it's not something that we really focused on very intently because of our sample size. The next was the first of our policy questions, which was the CMS approval, the CMS conditions of participation approval. So here we can actually decrease, which the way to interpret this is as you get more funding, you're less likely to agree with a policy that changes the requirements for you to continue getting that money. However, it is slightly mitigated by hospital size. So larger hospitals didn't react as negatively, and we think that that's relatively intuitive. If HPP money represents a larger percentage of the aggregate amount of revenue you generate or get from anywhere else, you're going to react more than if it's a smaller percentage. The second policy question, which was the IBA value-based purchasing program one, we have two relationships that we wanted to illustrate. So we regressed both of them on approval for the policy on quantity of funding and hospital size, as we identified pretty early on in the data analysis that the size of the hospital and the amount of HPP money they were getting were the only things that really made the other variables jump around that much. So what you can see in the first graph is as the hospitals get bigger, they again don't really want to, or they don't approve of the changing of the conditions. But if they have the immediate bed availability condition already in place, it doesn't change that relationship at all. So generally speaking, bigger hospitals, because they're bigger, they have more revenue generation, there's more money at risk, they just don't want to change. A little bit of a difference here when you go to quantity of funding, in that, again, the treatment variable here is immediate bed availability. And the way to read this is, again, similar to the graph I showed on the last slide with the hospital size. If it's declining in increasing funding, but if you already have the condition that we're asking you to change, represented in this case by the red line, you don't really care. I mean, it doesn't really affect your bottom line so much if you've already met the standard. Oh, excuse me. Just putting them out. So, again, the five main trends that we wanted to illustrate were preparedness funding, perceived preparedness increasing in the quantity of funds received, slightly increased on top of that by being part of a healthcare coalition, which is a vote of confidence in the healthcare coalitions themselves. Expenditures on preparedness across all categories, increasing in HPP funding, and increasing if you have more money lying around at the end of a financial period, or fiscal period. Approving of the CMS proposal, decreasing in HPP funding, for the reason I mentioned, slightly offset by having a larger hospital, because you don't care as much about the incremental effect of that money. The value-based purchasing program, decreasing in hospital size, unaffected by HCC membership at all. And the same program, again, decreasing like the CMS proposal in hospital funding, and slightly mitigated by having a pre-existing IBA, because again, you don't have to really make any change. So what we'd like to do is expand upon all five of these in terms of their implications for our study.
So this brings us back to our five research questions. The first of which asks, does membership in a healthcare coalition increase perceptions of preparedness? And we use perceptions of preparedness from hospital administrators as a proxy for actual preparedness. While we could not directly address this due to our sample size, we did use HCC membership as a treatment variable for the regressions that we ran to answer our second question, which brings me to research question number 2, which is, what is the effect of HPP funding on hospital administrators' perceptions of preparedness? So we did see a small positive correlation, and we saw that there was a stronger correlation if a hospital was a member of a healthcare coalition. So this suggests that healthcare coalitions are having some positive intended effects in bolstering emergency preparedness in hospitals. Now, if we look at that small positive correlation that we saw, regardless of HCC status, of HPP funding, so the amount that HPP funding increases emergency preparedness, this effect is marginal. So maybe this is indicative of a larger trend across a larger sample size throughout California. However, if this is as marginal as our data suggests, then even if there's a positive correlation, it still might indicate that this positive effect is not cost effective enough to be worth investing in. So this warrants further research to see how much do healthcare coalitions actually make a difference, and what's the increased effect on preparedness of each additional dollar of HPP funding. Our third research question asked, what is the effect of HPP funding on collaboration? So as we've talked about before, collaboration is a crucial component of emergency preparedness in hospitals, as identified by both the Department of Health and Human Services in the goals that they lay out for HPP, as well as the emergency preparedness coordinators whom we had a chance to speak to, who work with emergency preparedness on a daily basis. So our assumption was that more funding equals more collaboration. However, this correlation was not seen. And if this is in fact indicative of what's going on throughout California, then again, the Department of Health and Human Services should prioritize research into how much HPP and HCC membership is increasing collaboration. And if not, then what are the determinants aside from HPP that increase collaboration? Our fourth research question asked, are hospitals' expenditures well-rounded? So what we did is we asked hospitals in what categorical expenditures was their emergency preparedness spending over the past year. And we can see some of these are training, drills, communication systems, surge capacity, etc. Now, while there are limitations that we had in assessing the cost effectiveness of each categorical expenditure and how that might vary from hospital to hospital, we theorize that more categorical expenditures, so a broader spending, equals more preparedness. So if we consider a hospital who, let's say that they invest all of their emergency preparedness funds in training their staff. They have a very well-trained staff. However, come time to respond to a pandemic, let's say, and there's not enough personal protective equipment to go around, then that training is essentially rendered moot. And they're just as poor off as the hospital who didn't invest in all of that training. So we largely theorize that more categorical expenditures equals better preparedness. We did see, interestingly enough, a small positive correlation observed, which means that perhaps there is a positive and intended effect of HPP funding on the appropriateness of how hospitals are funding emergency preparedness measures. And our fifth research question looked at those alternative mechanisms for incentivizing emergency preparedness in hospitals. We have proposal number 1, which looked at CMS conditions of participation. Respondents somewhat agreed on average, and this was decreasing in HPP funding, and this response was less so in larger hospitals. We expected an overwhelmingly negative response to both this and the second policy for 2 reasons. One is that these are unfunded mandates that say, here are more rules, comply with these so you can get money. 2, Henry spoke about the American Hospital Association's response to these CMS conditions of participation policies, which was not very positive. So we were expecting to have an overwhelmingly negative response. However, we saw some responses that strongly agreed, and overall an average somewhat agreement that this would be useful in promoting hospital preparedness. Similarly with the IBA-based VBP policy, we didn't see overwhelmingly negative responses as expected. On average, respondents said that they neither agreed nor disagreed, so a fairly neutral response in how useful this would be for increasing hospital preparedness. The discrepancies between the responses for the first and second proposals do make sense to us. Hospitals are less likely, based on our responses, to fulfill the requirements for this second policy than they are the first policy. So we expected there to be a lower agreement score on average for the second policy. So where does this leave us? It leaves us with good springboards for further research. Namely research into a few questions that we think are really important to continue looking into. Number one, how effective is participating in a healthcare coalition on preparedness? Two, how cost effective is each additional dollar of HPP funding on hospital preparedness? Three, what determines how much hospitals collaborate with each other? Are those determinants related to HPP funding and HCC membership, or are they completely different? And if so, how can the Department of Health and Human Services use that information to its benefit to promote collaboration? And lastly, and this is something that we couldn't address here, but we do think that it's important going forward, is where does money go after HHS allocates funding to states, but before it gets to hospitals? Because that is still a huge black box. It's complex, it's very heterogeneous, and based on our interviews, we think that there may be some funding leakage going on. So this would be prudent to research further. In 2015, the Department of Health and Human Services allocated $255 million for this year's hospital preparedness program. Now, while we have seen evidence that maybe the program overall is underfunded, that's still $255 that's going into a federal program. So it's worth researching, is this money effective? How effective is it? And if we aren't seeing the results that we expect to see or hope to see with this money, then maybe it's time to look into either giving states less autonomy in how they allocate those funds, or looking into alternative mechanisms of incentivizing the hospital preparedness that we would like to see. Despite the diminishing funds that we've seen throughout the past decade, the importance of emergency preparedness and keeping our nation safe, prepared, and protected is still just as important.
We'd like to thank some people in accordance with this project. The first is our client, the Institute of Medicine, and Bob Cadlick, who supported us through this. We would very much like to thank all the people we spoke to in Washington, D.C. and in California who gave us their time and their attention. I'd like to thank the Public Policy Program staff, all three of you who were so supportive at essentially our stationery store for a couple months. And lastly, Joe and Ryan for their patience and support throughout this whole process. Thank you.
Questions from anyone? So first, you guys should not be, you kind of had started with your survey of almost embarrassment of we have a small sample and everything. You guys should not, 10% response, you shouldn't be apologizing for that. We're right to acknowledge the shortcomings, but 10% response to a detailed survey is pretty impressive. So you should, I wouldn't be sort of defensive on that end. Just state the caveats. That would be my thing. So why is there so much difference between California and Texas?
I think, there's a little bit of a demographic, but there's the difference in where Texas sets up hospitals. They have tons of really, really small hospitals for which they're in rural areas, and it's really easy to get them to comply. Rick Perry also kind of got out in front of a lot. He really dislikes Obamacare, so he tried to do a lot of it on his own. I actually, before I came back to grad school, worked with an organization that worked kind of with him to kind of change allocations within skilled nursing facilities and stuff. And he was actually, much more than I expected, very, very interested in making sure that his hospitals ran efficiently, making sure that they allocated funds appropriately, because he was trying to use it as a leverage point to say, we don't need Obamacare, get rid of it, it's not something we're interested in.
So is the state funding a lot more in Texas than California state? Is that compliment? Because these numbers don't seem like they're very big for a hospital.
No, so the amount of HPP money itself, no, but so to the point that we made, so we gathered information about revenue, gross patient revenue and net income for all the facilities in California, and it is true that, like Henry said, it's pretty much a drop in the bucket. So it's probably not the case that Texas's hospitals are so better prepared because of HPP funding. It's because they're just more efficient in general. The HPP funding is in some sense immaterial in terms of their overall efficiency. So they're probably retaining more money and able to spend it on preparedness measures that their state health board is saying, or state hospital administration is saying they need to.
So how much of disaster preparedness is a sort of one-time upfront fixed cost versus ongoing annual costs? Do you guys?
I mean, my answer is going to be it's hard to assess that because of the different types of preparedness. So, I mean, training is an investment that lasts. Drills are an investment that last if you don't have high turnover. Equipment sometimes is something that lasts, but other times is something that usually sits in a storage closet and then expires after a while. So that's another good question. I don't think we have enough data to answer it, but I think it's a variable across hospital based on what are their main investments. Did that sufficiently punt that?
Yeah.
Actually, Sarah, if you could clarify that, I thought maybe I misheard that you said if people don't have the categorical expenditures, the equipment, I guess that is, then that they do, if they have that, then they're as well off as those who are untrained. Is that right?
So when you mean in the discussion?
Yeah.
Yeah. So our thinking was that the broader the expenditures that hospitals are having means sort of more well-rounded preparedness, which we have determined mostly based on our interviews, is better because you can't sustain or you can't support trained responses to preparedness without the right equipment or without the communication systems or without the physical material resources to carry out those responses correctly. And the flip side of that is you can purchase a lot of things. There was a lot of reactionary spending in response to Ebola, and every time there's a sort of focused event on a public health crisis, a lot of reactionary spending goes on, but a lot of personal preparedness equipment doesn't do much without the training or without the capabilities to take on Ebola patients if it were that or something. So we just said, well, there are limitations to us knowing, across hospital to hospital how effective is training for this hospital versus this hospital. Maybe this hospital has a lot of personal preparedness equipment from the year before that we don't know about, so they don't need to do that for this year. But we thought that overall it was an interesting question, and we did see an expected trend that increased with funding.
And I think it's also, we didn't really want to get too bogged down presenting in how we actually coded these in. But as I was saying before, we did assume that not all expenditures are equal. So once you've seen, the first thing you might spend money on are drills, the next thing you might spend money on, training, and then drills, and then you're going to spend money on negative pressure rooms. So there is a hierarchy, so as you go up, you must be spending more money. Because you wouldn't just sit down and say, okay, I have $20,000, I'm just going to try and divide it equally amongst all categories. That, at least anecdotally, that didn't seem to be how it worked. So that was kind of, like, as you can see on this axis, it's not, it's just like number of categories they spend money in. So.
Other questions? Anyone else? I have to say that this turned out as well as it could have. Given the challenges that you guys had. I remember it was probably only 3 weeks ago. I think I saw Justin in the hallway, and I said, so how many responses do you have?
2.
And he said, no, I think your first answer was 0.
A day later, it was 2.
And then I remember it got to 7, and I was like, yeah, moving on.
And so we talked about, okay, what if they don't get above 7, or what if they're only? I mean, and then literally within, I guess, about a week or so, you guys were at almost 50.
I think one thing that we pass on to anybody else who's going to do this is, and Sara kind of alluded to this about how, especially groups of hospitals and care facilities that are owned by the same company, they generally only have one preparedness coordinator, and that preparedness coordinator probably wears a couple hats, but only goes to that meeting or clears that mailbox maybe once a week, if that, and they go to all the 5 facilities that Sutter Health runs. So, I mean, I got a lot of phone calls and emails after we closed this down. You know, probably, I'd say that if we kept this going for another month, we might have been able to double our sample size, simply because I think that people, it just took them a long time to get that letter, and that was really one of the limitations of the study, was if we'd been able to email it out, I think it would have made a huge difference, because they wouldn't have had to physically collect the letter.
But considering we started really on this project in January.
Well, and then to clarify, we tried very, very hard to get lists of emails within California and all across the nation. Our client Bob Kallick worked so hard to connect us with folks like the American Hospital Association, who politely declined our request.
And again, in the end, they ended up, you know, as they mentioned, they ended up handwriting. I suggested you handwrite the envelopes, which they did. And you did at least one follow-up, 2 follow-ups. So so you hand addressed 1,500 envelopes to get to that number, and so I mean you put a lot into it, and I appreciate that much.
I have a question actually. Did you see any, or were you able to get data for differences in like parts of California, or like more urban areas, more rural?
Not so much. We weren't really able to identify, like we mentioned, how the funding structure worked once it gets to the state level. We did. I mean, the only thing that we can really say about the difference in the regional differences in the state is we did get slightly more responses from the Los Angeles area than we did from anywhere else. That could be because it's just a bigger metropolitan area. That could be because in Los Angeles, you know, they're right on the fault line. Like the air quality sucks. Maybe they're thinking about it more. You know, they're not in paradise up here. So that could be why. But
I think that is really another very important question to ask, though, is are urban hospitals more prepared than rural hospitals? And because they're going to get a different population of patients coming in too.
So how come it was so hard to follow the money?
There was just absolutely, I mean, nobody could even really say, so we could find out how much money went to the state, but then nobody at the state level would really tell us, either respond, or tell us how they even thought about giving money. And none of the facilities themselves had any idea of why they'd really got the amount of money that they had. I mean, some of them said, yeah, we get $20,000, and honestly, we don't even really care about it because we fund it on our own. I mean, some of the private hospitals were like, look, we don't like the inconsistency, we don't like the variability, we just set it aside. We set aside money to fund these initiatives that we think are a good idea, and you know, we have an expected value for the cost of something going wrong, whether it's a car driving into the front of the hospital or, you know, a pandemic. And so we do it on our own. And other hospitals said, yeah, you know, we're out in the San Joaquin Valley and we get $5,000 and we beg and plead and we get no more, and we have no idea why we don't get any more. So the ability, and this is kind of goes to one of our research questions, or sorry, one of our continuing research questions for other people is, you really have to get both ends of the pipe. And we weren't able to get both ends of the pipe. And I think that, I suspect that you have to pay a bunch of money to get both ends of the pipe.
There's also no one aggregating all of this information. So we can't even, I mean, maybe if we had more people responding, then we would be able to have a decent estimate. From this, we don't really think we could, but we don't even know how much money just gets to hospitals, because we know that there's money that is funding HCCs and funding administrative positions, but we have no clue what portion of that is being taken off the top.
We actually also spoke to people at the Department of Health and Human Services who are part of the hospital preparedness program, and they were unable to tell us as well.
So it sounds like you guys should coordinate with the group from yesterday that talked about it.
I was about transparency.
The accounting systems.
Yeah, I was just going to say, the issue with answering that question is that it's fundamentally an accounting question. Because you have to be able to sit there and say, okay, like, look at your statement of cash flows, and like, you know, where do we think that this money came from? Like, we spend a bunch of money here. What account did we draw down to do that? Did we draw down the HPP? Because the vertical feedback for this program is, here's a bunch of money, spend it. And that's also, by the way, why you see such a, if you get more money, you spend it, is because you, I mean, there's no reason to say we got too much money, here's some of it back. So it's a 1 to 10 scale in terms of what they report back to their state that goes back to the government. And you know, if you report that you're just fine, you know, if your preparedness is a 1 or a 10, you don't get any more money. So everyone kind of just like meanders around the middle, so that no one really checks and no one really takes the money away.
Yeah, and that's what Health and Human Services wanted to do. They wanted to figure out how to, instead of making like paper-based surveys of how hospitals are prepared and how much funding they need, they wanted to send actual people down to these hospitals and survey them individually. And then that researcher then spoke to the head of Healthcare Preparedness Program, and she said, well, that's kind of unrealistic for us. We don't have the resources to do that.
Yeah. It's very similar to what Mark Duggan was talking about the other week, which was, no one gives up a free lunch if you just ask them if they'd like to give it up.
I mean, there has to be somewhere there is a money trail somewhere out there. I mean, it's public money, so it's in theory. Well, it's got to be publicly available. The question is where.
And we
Just
try.
ask the pension guys.
What's that?
Just ask the pension guys.
Just ask the pension guys.
We also wanted to. We entertained the idea of also, you know, going. Okay, well, let's look at HCCs and survey HCCs instead of individual hospitals. But it is impossible to find good information on HCCs because there's no collaboration between. I mean, maybe not none, but there's no. It does not appear that there's a coordinated effort to collaborate between HCCs, and these, like, when you go on their websites and stuff, these literally look like a few guys made a website and are talking and know some people in hospitals and stuff. I mean, it's really there's no aggregated information for the state, and it's really disparate and heterogeneous.
But this just happened 5 years.
Right. I think that may reflect the fact that this entire program was a reaction to an event that happened, to the anthrax attacks, and so it wasn't planned with a lot of thought into the future.
Did you get a sense of whether do you think that some of that leakage may be occurring in HCCs, or
Probably.
Some people said that. Yeah.
I mean, that's a suspicion, but there's no.
It's probably occurring at
I mean,
this level.
my gut reaction, tells me that, well, if there's money disappearing along the way, these HCCs kind of emerged out of nowhere, and they had these websites that looked like they were designed by 9th graders. Or
They would look good then.
Yeah.
Okay.
They look like by 50-year-old guys.
An elementary school computer lab.
And it's not transparent. I mean, that's sort of, that's me being a conspiracy theorist. But
yeah, there were definitely some people who said, there's a significant haircut that goes on here.
Yeah.
There were some people. We spoke to at least one person who named some names too.
Yeah.
We didn't really have any means of, doing an expose on an individual administrator.
And one of the reasons I said that is because of your experience with Tim, the Kiwi guy. Where was he?
Yeah.
Because they had an experience with someone who runs an HCC.
No. He does consulting services on how to put HCCs in places.
Ah, okay.
Yeah.
Oh, he also has a separate organization that's like a private for-profit HCC. So there are two, like a national, like nonprofit and healthcare coalitions, and his own healthcare coalition in the state of Indiana that's private.
But there was a clear profit motive for him
Yeah, I mean,
somewhere along that.
he's not the
value
only
chain.
one that does this. I mean, they're similar to. I mean, all the big consulting companies have wings that do this too. You come in and say, oh, we're not preparing very well. Analyze this, give us some new recommendations, and by the way, take some money out the till on your way out because you're fee for service.
Great job.
I want to say how wonderful the presentation was. I mean, so
Thank you.
polished,
Very well.
incredible speaking, everyone, really solid explanation of all the content and the research you've done, and just so professional, really.
And you all look forward, not back at the screen.
Oh, it's terrific.
Thank you.
Great.
So, thank you.
Thank you.
It's great.